becoming proficient at calculating osmolarity. And this section I shamelessly stole from Dr. Bill Schrader. I believe he's here. I think he might be lecturing. And so that's him. This is him that I've stolen. And the eyes in here are his eyes, not me. This is him, Dr. Schrader. I can't tell you how many patients we see who have virtually no veins because of multiple previous IVs which have been given in normal saline with hypertonic nutrients rather than sterile water for infusion. This is because, I'm reading off page 46, this is because osmolarity has not been calculated and/or nutrients have just been dumped into an IV or medication added in hospital solutions. In many cases, nutrients or drugs were just added to normal saline without regard to osmolarity. This is especially a problem with vitamin C and magnesium as they have a very high osmolarity. Now, to go back to where this section starts on page 40, he kind of says the same thing there at the very beginning. And osmolarity and osmolality, they sound similarly close. And I understand it, but I don't know that I do a good job of explaining it. And so if someone's really good at explaining it, please stand up and do so. This gets into the basic chemistry and stoichiometry. And the osmolality is a term of concentration, whereas osmolarity is a term of pressure, if you will. And if you take any of our red blood cells and drop it into a cylinder of water, water likes to have the same concentration everywhere. And so the water will seep into the red blood cell and the red blood cell will lyse or explode. That's not good because it takes a little bit from bone marrow to make a red blood cell. And so you don't want to put in a solution that is hypoosmolar. Now, at the top of page 41, this might be a better place to start. The normal osmolarity of our plasma is somewhere between 0.28 or 2.280 and 0.310. That's milliosmoles per milliliter. And if you convert it to milliosmoles per liter, then it's 280 and 310. Y'all understand what we did there? Instead of, because it's interesting, he says for our purposes, I'll always talk in terms of milliosmoles per milliliter, but then right down below it, he's talking about milliosmoles per liter. In other words, if you've got a large vein and you're going to do a push, you can get away with a 1400 osmolarity. Medium vein 950, any vein 400. And then if you do an IV, a slow drip, 1200 is your osmolarity for a large one, 700 and 400 once again. And so, kind of say, gee, if the safest place to be is probably a little bit closer to 400 for all comers to protect the veins. And it's important because if you've got someone that's coming in and going to do 40 IVs, you want to protect those veins. And so those are some really important numbers to remember there in terms of what you want to do, because you don't want to put in a solution that is under that, because you will cause the red blood cells to lyse, cause hemolysis. And it's easier for the body to rehydrate a red blood cell than to go have to make a whole new one. Then you get all the hemolysis hitting the kidneys and all that kind of good stuff, just not good. And so Bill does a really good job of going through all this, but his lecture is usually a couple of 3 hours, and so I'm not even going to try to pretend to go through it. But on page 49, he lists there the osmolarity of pretty much most of the things we're going to be putting into an IV. And so it's, in other words, it's don't just add things because you think it's a good idea, because you might end up hurting someone. And so, uh, this is the kind of thing that Dr. Myers did, figuring out the dosages for the Myers cocktail. And if you want to make up your own IV, figure out the osmolarity of your contents and make sure that you're in bounds and you're not, like I said, you're not going to hurt someone. And you've got these different equations here, and he goes through how to figure out what the osmolarity is, how much water do I need to add, half normal saline, and calculate it out. And he gives several different examples. And he does on page 45, does an IV of vitamin C, but adds some other things into it, and goes through how he calculates how much water to add to it. Then you'd have to look at see what the osmolarity is. And now we've got the convenience of having our wonderful cell phones, so we can, I would imagine we get the osmolarity of just about anything. And I believe I forgot to include this, but this is from and this is probably what they're using in TACT. This is a standard EDTA formula, and calculated the osmolarity of the formula, and in our office, we have an IV protocol book, and try to keep it updated. And so it's a recipe. It's like a cookbook, if you will, but keeps everybody on the same page. So if you know what you're doing, you're doing the same thing all the time. Left you guys out, didn't I? Thank you. And then over on page 52, and I didn't write 52 on there because I didn't know if you were going to copy it, you wouldn't want a 52 written sitting on it, so I didn't number that page. But these are some of the protocols that Dr. Schrader uses in his office. And then on page 53, he developed most of these protocols. He didn't develop the Myers cocktail. And I'm almost positive that he has a book. Dr. Schrader has a book out that has a lot of different information in it about some of these different protocols, because things get really kind of interesting over there on page 54, where he starts going into different protocols that you can use in your office. Kind of a neat gold mine of IVs and IV information, isn't it? And I was asked where we get our supplies from. I kind of don't know. My nurse does the ordering, and my practice manager oversees it, and we've got the protocols in place. And so I don't really. I know that we get our IV vitamin C from McGuff because they have corn-free, preservative-free, um, and so. And also, some of our local compounders will make up some of the additives we use. And some folks will use the compounders to make up the IV, make up the whole thing for them. They don't make up anything in their own offices. And I'm not certain, as anybody know what the regulations are in terms of making up your own solutions in your office? I think so. You're supposed to have a hood. Yes, sir. Could y'all hear? The There was I don't remember how many years ago it was that Massachusetts, was it New England, the New England Compounding Pharmacy put out a whole bunch of contaminated steroid injections and killed a few people, and the FDA uh, used that opportunity to make life incredibly difficult for compounders as well as practitioners. And if, like you just said, if you make up an IV and you add more than 5 things, you're considered a compounding pharmacist, not a doctor. I mean, you know, this is another reason we need to have state medical societies to say no, this is wrong. Just use sterile technique and let us go. So proceed with caution. And at the very end, I put in these are urine challenge tests of mine because in my clinic I'll tell, since the patients are paying cash for them, I say, look, we'll do this test whenever, however many times you want. However, and I'll show this to them and say, if you're looking to see a significant change, it's probably not going to be there. And because the hard thing to remember is that the urine challenge test, these results just show what comes out. It doesn't tell you how much you've got in your body. We can't give that answer. I don't know of any way to do that other than the multiple biopsy, procedures. Now, on page 68, they're on between 1998 and 2011, I'd done about 60 chelations of EDTA, and with 20 of them I did DMPS. And I was kind of surprised that much came out. I was like, whoa, what? Yeah. And so in December of that year, I rechecked it thinking, no, that can't be. And silly me, they're still coming out. And by December, I'd done about 80 chelations. And then on page 69, took a little break there from doing doctor's data. In 2014, maybe they are coming down. Yeah, stuff's working. I'm not peeing out as much. And then that just got shattered by the test there on 2015. Oops, just kidding. There they are coming out again. And then on the very back page is from 2016. And I was hoping I would have 2017 back by now, but I don't. So it's in the that doctor's data in the oven right now. So it's been estimated that one would have to chelate on a very regular basis for at least 15 years in order to kind of get to where you're not going to be having much coming out. Why did I do this? Why not? Had no clue, felt no difference. Now, I just gave you an example of the blood pressure. You know, we're taught that 95% of the blood pressure is idiopathic. You know, horse feathers. You know, did you have blood pressure when you were 10 years old? No. I mean, 20, no. Okay, so, you know, something has been added to the equation. And so I didn't have high blood pressure, thank goodness, you know, knock on wood. But that's one of the things, if someone has high blood pressure, you know, they don't have a procardia deficiency or a, you know, whatever. And so, like I said, with the ladies, it's a really good idea to, you know, say, hey, there's a good chance you got metal. And the problems with the metals is they mess up the enzymes. They just screw up our metabolism, and it's never in our favor that they do this. It'd be nice if we get exposed to a metal and become smarter or stronger or faster or something, but it just doesn't work out that way. I think it's a different methodology. Is there anything we need to review, go over, talk? I mean, talk about, explain? And like I said, give us your feedback. What needs to be changed? What can we do to make this better for the next group? And also feedback on which form did you like. I mean, and it doesn't matter to me. I mean, they're both on the computer, so it's, you know, do I push this button or that button in terms of reproducing it? So it's not like it's a, you know, so, I mean, any kind of feedback would be more than welcomed. Yep. Her question was about chelating out aluminum, and EDTA will do it. Well, the N-acetylcysteine doesn't, well, we take the N-acetylcysteine, so our bodies will up the production of glutathione, and glutathione activates the enzymes to get the metals out. And I think it's pretty much all of them. Glutathione is good stuff.
You think the liposomal glutathione works?
She was asking about the liposomal glutathione. I really don't know. So, the liposomal stuff is really interesting in terms of the vitamin C, B12, alpha lipoic acid. They've put a lot of things, liposomal them. And are they that much better? I honestly don't know. Of course, they swear they are. Okay. Well, I mean, and I've looked to folks that have had experience with it to say, oh yeah, this one's better. I like, you know, I've had this result. Has anybody had any results or? Anything to say about the liposomal concoctions? Huh? They're expensive?
No, comparison, I wouldn't know.
Yeah, I mean,
Say so, you know, how much am I going to for doing more data doctors? I like the phosphatidylcholine stearate.
mhm.
Because that'll help the cell membrane.
Yep.
To get some of the trans fats out of it.
So I don't know if the liposomal, I don't know if it's hype or if it's actually that good. Anything else? Well, heck, let's go eat lunch.